All right. Well, good afternoon, everyone. Thank you for taking time out of your busy holiday schedules to join us. On behalf of the Midwestern Public Health Training Center, I'm Janelle Ali-Dinar. Thank you for joining us. I wanted to give you a little bit of context about who we are, what we're doing, and why it's so important to highlight the webinar that's being hosted today. The Midwestern Public Health Training Center is one of 10 regional public health training centers in the United States, funded by HRSA, the Health Resources and Services Administration. It serves 4 state regions of Iowa, Kansas, Missouri, and Nebraska through its goal to improve public health by strengthening the technical, scientific, managerial, and leadership competencies of a public health workforce. Each of the 10 public health training centers has a designated national content area. Content areas is diabetes. So the NPHTC formed the National Diabetes Training and Education Advisory Committee, of which I'm a member of, engaging in regional and national partnerships in diabetes prevention and management to shape diabetes content areas. And our advisory committee has provided an ongoing input into the development of diabetes content area in several key areas. We focus on national education and training advisory opportunities, ongoing identifying gaps of awareness and current strategies in prevention and management of diabetes, looking at promoting the NPTHC website, and highlighting and showcasing practices of innovation in diabetes prevention and management and population health, as well as supporting and implementing regional and state summit efforts. We have an MOU with the Region 7 Heartland Health Equity Council, of which we highlight social determinants of health, health equity, and focusing on underserved and minority communities. Today's focus is going to be on innovation, best practices, and models around health equity and the duplication of such models for specialty populations such as refugees. Our two presenters, and you can tell they're academics because they're very humble in their bios, is Dr. Sheila Dorsey Vinton, who is the Executive Director and CEO of the Asian Community and Cultural Center in Lincoln, Nebraska. She focuses and works in immigrant and refugee populations around a number of issues, including access to family resources, minority health education and advocacy, domestic violence services, and other services where their language is a barrier to access. Her PhD is in nutritional anthropology, and she serves on the Nebraska Office of Minority Health Advisory Council. And also Dr. Susan Wertman, who is an associate professor of sociology at Nebraska Wesleyan University in Lincoln, Nebraska. She is a skilled and award-winning professor with an emphasis on race, class, and gender and women in prison. She teaches analytical and research skills and emphasizes service learning in her classes. She is a strong community advocate that works with multiple nonprofits with grant writing, program development, and evaluation. I give you Dr. Sheila Dorsey Vinton and Dr. Susan Wertman at Eat, Play, Live, a case study of one community cultural center strategies to support refugee and immigrant health around diabetes.
Great, thank you, Janelle. Good afternoon, I'm Sheila Dorsey Vinton. I'm Executive Director, CEO of the Asian Community and Cultural Center in Lincoln, Nebraska. I am not a doctor, just to clarify, but I'm very, very proud of the work that we've done at the Asian Center. And I wanted to give you a little context about how both I and Susan Wortman are connected to the project. So this project emerged out of graduate work that I did in refugee and immigrant studies, specifically regarding food deprivation and an increased incidence in diabetes. And then also, as we interacted with clients at the Asian Center, at the Asian Community Cultural Center, we realized it was a problem and that we needed to do something about it.
Yes, and I'm Dr. Susan Wertman. I'm a full-time professor at Nebraska Wesleyan University. I do a lot of community work, as Janelle mentioned, and I've worked with Sheila for probably the past 4 or 5 years around different issues at the Asian Center. My students have served internships here. We were working on a grant, I don't know, about 4 years ago now.
Yeah. And so here's just the presentation overview that we're going to discuss today. We will introduce the peer supporter community health worker model that we use at the Asian Center. And Sue will discuss some of the information that emerged from our focus groups in part 2. And then we'll discuss some practices, activities, and community strategies that we've implemented and give you some time to ask questions and have a discussion. So first of all, as a point of background information, we should say that Lincoln is a refugee resettlement location and has had the largest per capita resettlement in the US last year. That's even with that high number, it does not take into account the large number of secondary migrants that come to Lincoln after being resettled in other areas. So Lincoln is a growing community of many people who are refugees and also who are immigrants. And it's been growing at a phenomenal rate in the last 10 years at least. There are over 60 languages spoken in our public schools. At the Asian Center, our staff speak over 13 languages, just as evidence of that fact. The Asian Center was founded at the time of increased resettlement of Vietnamese refugees in 1992. And our mission since 2006 has been to support and empower all immigrants and refugees while sharing our cultures with the entire community through our programs and services. This is a staff photo from a few years ago. As I said, our staff speak around 13 languages and use their skills to offer support to all the members of the community. We currently serve over 1,000 unduplicated clients per year, primarily from the listed populations that you see on the screen. We do this through intensive case management, which I'll explain in just a minute. We use a peer supporter model for our program delivery. And what that means is most all of our staff are immigrants or refugees themselves. That means they understand what information and support are needed for our clients to lead successful and happy lives. And they bring their language skills and a passionate desire to help their community members. Our community health workers have training to be community health workers. They did that training through a course that's offered through our state. They're trained as breastfeeding educators. They've had training as domestic violence advocates. They've had numerous meetings with agencies around town, such as legal aid and other places where they have learned how to get their clients into these services and whatever that they need. They're essentially community connectors, and if we don't offer the direct service, they will connect the clients to the services that they need. So they serve as cultural brokers. Our staff work both one-on-one and in group education classes. And as part of that, they help schedule doctor's appointments, track A1C results, and they do that with really close collaboration with especially our People's Health Center, our low-income clinic in town, and Urban Indian Medical Center. They are really familiar with the staff there so that they can work together to help clients manage their health. They take the clients to diabetes support groups. They hold diabetes self-management program classes. We just had some staff who received training to offer those classes in Arabic and in Karenni. And that's a 6-week intensive class that they do. And along with all of those things that I mentioned, we also teach language and citizenship education at the center. So in a typical day, a community health worker might arrive to have 3 people waiting for individual support, and then they might read the client's mail, sort out billing or appointment issues, and make medical appointments in the first couple hours of their day. Then they might take a client to a doctor's appointment and record and track their A1Cs in partnership with their healthcare provider. And they'll help monitor the client's health, and they'll help them remember when their next appointment is, or some things that they might need to do to manage their care. Then they might return to the center and offer group training in diabetes self-management. And if there's any issues that arise in the class, then they'll spend the next hours after the class to help figure out solutions to the problems that they encounter over the phone. So they have very busy days. They have a lot of client connection, and they might see the same client once a month. They might see them several times a week. It just depends on the needs of the client.
So I want to talk a little bit about the clients and diabetes challenges and kind of some of the results of the Community Health Endowment Grant that we were able to, or some of the challenges that we were able to take a look at. And then Sheila will talk in the next section about some of the things that we were able to do. And she's already told you some of the great things that they are able to accomplish, partly because of this grant. So I'm going to start out with kind of rewinding back to 2015 when Sheila and I were sitting in the office working on a grant, and I already sort of alluded to the fact that we had a client, or one of our community health workers telling us about a client who she wasn't really able to serve at the time because we just didn't have the resources for it. So when we were sort of hearing these initial stories in 2015, we applied for this Community Health Endowment Grant for diabetes awareness, prevention, and care. Prior to that, we didn't do any screenings for diabetes at the center. We weren't able to do any diabetes education. We weren't able to track and to even understand how many of our clients might have it. At that time, we only had, Sheila talked about the community health worker model, but at that time we only had one community health worker. Now we have 6. And so our staff weren't trained in sort of that community health work model. And we were only able to serve our Vietnamese clients in any sort of health capacity. So there were lots of other clients that we really wanted to be able to do something for. Also, since Sheila has an academic background and since both of us were interested in diabetes and diabetes risk, we knew from our background and from looking at the literature that there were lots of risk factors that this population had. So for instance, the Sudanese and Karenni population had spent significant time in refugee camps and or had a significant history of food deprivation. All of our clients except probably the Chinese group, but even for our Chinese clients, there's a history of low income, so they weren't able to afford medical care so much, and some of the just education and food that they might need to take care of diabetes if they had it. And all of these groups are non-English speakers.
And many of them didn't even know that they had diabetes. Or if they did know it, they weren't managing it because they couldn't manage it.
So one of the first things we were able to do when we excitedly found out that we had the grant was to do a series of focus groups. And with that, we also partnered with Dr. Joan Gilbreth. She's a colleague of mine at Nebraska Wesleyan, and she's also in the sociology department. And what we wanted to do was to speak to 3 different stakeholder groups and find out what they saw as some of the challenges and barriers to care in Lincoln, and how we might sort of maximize, after understanding what some of those were a little bit better from everybody's perspective, how we might sort of maximize our services around that as well. So we conducted 8 focus groups over 6 months. We spoke to community healthcare workers at the center, who were becoming community healthcare workers at the time, but they were staff. We spoke to community healthcare providers. And then when we also spoke to the clients about their clients that we knew had diabetes and some of the challenges that they were going to report to us. Those groups were, all of them took about 2 hours apiece, and we had lots of data after that was over with. And I'm just going to tell you just a few things about what we found so that you can understand how we also tried to put some of that into practice. So this is kind of a messy slide, but basically there was some agreement over all of the groups of some of the challenges and barriers to care. And it comes as no surprise to any of you, I imagine, that language barriers and interpretation challenges were spread across all of the clients, community health workers, and community healthcare providers all said this is really a challenge to providing service or getting service around diabetes. We also found that a shared challenge was just the issue of medical care access. And I will talk about each of these top 3 challenges in just a minute. And then another challenge I think that was kind of widespread across all of our groups was the need for education. So for community health workers, there was a need for education to become community health workers and provide services. For community health providers, there was a need for education about culture. And for clients, there was just a need for education all over the place about diabetes management, nutrition, compliance, and all of that. So to the first one, the language barrier issue, one of the stories that kind of emerged out of our focus group that might be interesting to you to share is that even when people recognize that there are language barriers and challenges and they try to make accommodations for that, when healthcare providers try to do that, even sometimes your best laid plans for that don't always work out very well, because one of our PAs told us that she had a client who she was trying to communicate with, and she thought maybe the best way to tell this client about using insulin would be to say, okay, well, when the sun comes up, you will inject insulin in the morning, and then you'll inject insulin at night when the moon is out. So she had shown some pictures and tried to explain that. And when the client came back 3 months later and their A1Cs were a lot worse, she was trying to understand what had happened. Well, it turned out that a sun and a moon didn't account for days that were cloudy, and there had been a lot of cloudy days in that 3-month period. So the client hadn't known that they were supposed to be using their insulin when it was a cloudy day and they couldn't see the sun. Oops. Another finding that we had, I think, around our language barriers, I think I went, oops. Is that there were barriers that we might not have thought about around language in general, or that our healthcare providers hadn't necessarily thought about. So for instance, if an interpreter was there, then some of our providers felt like the interpretation might have been going okay, but when we heard from our community health workers, what we realized is that the quality of the interpretation wasn't always very good. And so that even if there was interpretation being provided, patients sometimes really weren't getting much of knowledge about their care. Another thing that happened with interpretation is that some words just don't sort of translate one for one into another language. And so sometimes it takes a very long time to explain something that seems very brief in English. And so sometimes that could be confusing for the providers who didn't really know what was going on, what was happening in interpretation.
So they were feeling really frustrated or not, they didn't really trust the interpreters that they were doing what they said that they weren't doing it accurately, or at least they didn't feel they were.
Right, exactly. And then there were sometimes those interpretations took so long that within that sort of small amount of time allotted for the appointment, it wasn't necessarily easy to get all of the education across. One other thing I want to talk about is that sort of third theme with the need for more education. We really saw that clients had a lot of myths about diabetes, and kind of depending on what community they were from, what kind of myths they had. So there were lots of people who were our clients who didn't think they had diabetes at all. They hadn't thought about it. Their medical providers didn't think that they had diabetes because they didn't have a high body mass index. So they didn't kind of fit the profile of typical people who'd have diabetes. A lot of them thought that their maybe diabetes medication, if they had some, could be supplemented with medication from their home country, or that they should stop their medication if they were getting better. One of our Sudanese respondents told us that she believed that diabetes was a rich person's disease, and that was something that culturally was like almost a desirable disease to have, because rich people get diabetes and poor people get malaria. And so in some ways it was almost a status booster to have diabetes. And some people just thought that food wouldn't give you disease, or that there wasn't a problem with food, so you just needed to take medication. So we saw lots of myths and educational opportunities.
Yeah. Or sometimes that if you took medicine for something, that would guarantee that you had it, even if you didn't think that you would have it, but medication would ensure that you would get it.
One last thing that we found when we were doing the focus groups that I just want to spend a minute with was when we were talking to some of the clients, we realized that there was such a need for some intervention, because we talked to people, for instance, Ms. E, a Karenni refugee, told us that she had been recently hospitalized for a blood sugar that was over 700. Her husband was working in a factory, and he was getting so frustrated with her diabetes, he just felt like insurance was too expensive and maybe he should just take her back home. And so there was a lot of need for education on both the part of the client and the husband. We also talked to people who just really needed to be matched up with medical services. We talked to a woman who was diagnosed with diabetes in 2006. She hadn't seen a doctor in 3 years. She'd never had a glucometer. We talked to another client who had diabetes for quite a while, and he had recently gotten a new glucometer, probably maybe 3 months before our focus group, but he didn't know how to use it, and so he wasn't using it at all. And he had been told to check his blood sugar every day, but it was a matter of language. He wasn't sure how to use it. So lots of different stories about ways in which our community health workers could assist. So again, after we received the Community Health Endowment Grant and we were able to do the focus groups, find out a little bit more, we were able to train our community health workers and really start putting things into practice. We knew that there was lots of things that we had to do to really try to get an active response in our communities. So one of the first things that the grant kind of allowed us to do was, I know this is a bad picture, but it allowed us to establish for Dr. Gilbreth to work with us to establish some sort of database so that we could even just start recording some of the information about our patients or our clients around diabetes and their diabetes care, and how often they were coming in and seeing our community health workers and what kind of services were being provided from the community health worker perspective. We were also able to establish later on a system of monthly case management documentation for this diabetes project, so we could really track how many people we were serving and how that might fluctuate by month and what kind of activities we were doing. So that was really helpful to see some patterns. We also started requiring our community health workers to do case management reports around this grant, because we really learned some interesting things about how intense it was for the community health workers to work with these clients. And so you can see from this report that one of our community health workers was spending a lot of time with one of these clients talking about her A1C, how she eats her food, how she does her exercise, how she controls her diabetes. For another client, she just got to know that he wasn't taking his medication on time and he wasn't taking it regularly. So she, was able to kind of encourage him to take his pills And then she also was able to sort of talk about, okay, these are some things that can happen if you don't manage your diabetes.
She showed him some scary pictures.
Yeah, scared straight.
Yeah. And so through this project and another grant, we really wanted to reach large numbers of people. One of those ways was to do community screenings. And our festivals that we have at the Asian Center regularly attract crowds of 600 to 700 people. And so we used partnerships with UNMC nursing staff and students and Nebraska Wesleyan nursing students to provide screenings at these events. And they would track the folks who needed referrals to our community health workers and then hand off that information to our CHWs, who could then follow up with potential clients and new clients.
As an educator, one of the things that I really love about what Sheila's done at the Asian Center is that she works with nursing students around cultural competency too. So they're not only sort of learning how to administer some of the testing procedures, but they're also really working with diverse populations.
We talk about common myths and things that they need to think about when they're doing their care. The other thing that we do is center screening. So we try to have kind of an intensive look at diabetes during the month of November, since it's Diabetes Awareness Month. But we also do quarterly screenings for our existing and new clients that helps them get a handle on their disease and track if they're making progress or not. There are opportunities during these screenings to find new clients that might benefit from more intensive case management. We also offer that intensive diabetes education I mentioned before, and they can go to other programs that are offered at the center. So our domestic violence program provides us the opportunity to have sewing circles where women can come together and they can sew, and then they can discuss with the other members of the group about domestic violence issues that they might be facing. But it's also an opportunity for us to do health education at that time and financial education at that time and any other sorts of things that we really want the ladies to know. And we do the same thing with our senior programming and any other programming that we have. And I mentioned before about the value of the partnerships that we've had with the grant, and that includes our diabetes coalition in Lincoln, Lancaster County called Action Now. Through that, our community health workers have contacts with so many diabetes educators in town, so they have some resources to draw on if they don't feel comfortable with providing all of the information. Also, our state-funded prevention program, the Minority Health Initiative, that is this grant that we've been talking about is kind of a way to expand on the Minority Health Initiative. Aging Partners is a good partner with our senior programs, and they help teach classes also, and that includes exercise and nutrition and all of that. And then, like I mentioned before, the nursing departments. And as part of the CHE grant, we wanted to make sure that providers learned the information that we'd learned in the focus groups, as well as the clients. And so for the clients, we created a newsletter to help dispel those myths that we discussed, that Sue had mentioned. And for our providers, we held a series of lunch and learns. And we wanted to discuss with them that many of the immigrants and refugees that they might be seeing don't necessarily look like they have risk factors for type 2 diabetes. And in fact, when we've done screenings at the center and they've taken those little risk factor tests, they almost always come away with not having any risk factors, but they already have diabetes. So they're like, what? This isn't a useful tool at all. And we agree with that. So we have to expand the notion of risk in these clients. And for, the providers really need to know about this expanded notion of risk.
One of the other things that we have tried to do as part of the grant, and we're working on this more this year, is to do some prevention activities with not necessarily our target groups, which in this grant, I don't know if we said this before, but we were targeting groups 40 and over. And so we've really been reaching out to our youth because we have a series of youth programs. And also we are intending in the next couple months to reach out to pregnant women. So one of the fun things that a couple of the staff put together were some just activities for our Young Women's Leadership Council and our Young Men's Community Council to talk about nutrition, to talk about diabetes, and they were having fun with it, but they were also learning. And so we feel like they also know that people in their families have diabetes, and it helps them to kind of understand what their family members might be facing, but it also helps them to understand how to make good nutritional choices and be physically active.
Yeah. We're ready to take some questions or have some discussion about this.
So we did have a question here that says, we would love to duplicate your work in our community. What steps do we need to take to do that? And what advice would you give us?
Well, I think that we're really lucky in Lincoln that we have a community health endowment that really focuses on raising the health of our city. So we have that to apply to. I think that you could implement this peer support model with community health workers in clinics and in community centers. I mean, we're a community center, so we know that people come to us for whatever they need help with, and that includes their health, but it includes so many other things. Maybe even your city community foundations would be a good source of funding. And if you live in a large enough place, a Robert Woods Johnson Foundation grant or something like that would be a good source of funds. And then our state offers some training for community health workers. So they can take, it was quite an intensive training, really. It was 9 months training to become a community health worker. And they had to do a lot of activities and gather a lot of information about health.
Also, I would recommend, like I said earlier, I think Sheila's been really great with maximizing her partnerships in the community. So we're fortunate that Lincoln does have a pretty robust community health, lots of different ways in which that can be accessed. We have 3 colleges here, so Sheila was able to work with them, but also she works with Aging Partners and she works with Action Now. And so all of those have really provided some resources and education in addition to what the community health workers have been able to learn. So those are groups that come in and they don't charge to do services. And so that's been a really no-cost way of increasing response to some extent. And I guess one of the questions that looks like someone asked is, how do you train your community health workers? I think Sheila kind of talked about that program that was available to them through the state of Nebraska, and they have like a community health worker certification.
Yeah, it's not an official certification, but they got a completion certificate. There are no real specific risk factor questionnaires. One of the resources that we found was through the Joslin, what was it?
Joslin Diabetes
Foundation. They have some materials that they've created for Asians and Asian Americans. I mean, you could just add a few more questions to regular risk factor questionnaire that you might get from the CDC. I would recommend that you would add, have you ever experienced food deprivation for a prolonged period of time? Then there you go. Are you over 40? In the case of Asians, if they're over 40, that is a risk factor also.
Evidence-based curriculum.
Well, so the training that our community health workers are providing is an evidence-based curriculum. Their diabetes self-management curriculum is evidence-based.
We know that there are a couple of evidence-based curriculums out there to be implemented for like programming. One of the challenges that we faced, I think, along the way, and Sheila, correct me if this is wrong, but I think that a lot of them are translated to maybe Spanish, but a lot of them require translation on the part of our community health workers, and they have limited time to do translations. So a lot of times it's been easier to maybe adopt like just some small things that we've found, you know, when they're not translated.
Right. And some of those aren't necessarily meaningful in other cultures, right? So showing people what foods they should eat should be culturally based and not really. We had a lot of fun taking people on trips to the grocery store. So we take them to our local store, which is a Hy-Vee, and show people broccoli and things that we take for granted as just normal vegetables, right? Are vegetables that are unfamiliar to so many of our clients, and so they have no idea how to cook them. So we take them there and they find it really exciting, and then we teach them how to prepare those things too.
I'm not sure if you can see the chat, but there were questions that said, do you guys help with refugees and or immigrants as well? And also any eligibility guidelines for your services?
So yes, our services are all geared towards refugee and immigrants. We, at the Asian Center, that's who we serve. That's our primary client base. Can you tell me the second part of that question?
It says also any eligibility guidelines for services.
So there are no real eligibility guidelines other than if people come in and they have a language barrier that they need help with. So if they come in our door, we assume that they need us.
That's fair. And then what steps did you take to gain trust with these populations?
Well, I think that the biggest source of establishing trust is making sure that your community health workers are peers. So our community health workers, as I said before, we use this peer supporter model where these are our staff. There's some feedback there. Our staff are refugees or immigrants themselves, and they have experienced just about everything that the people that are coming to them now are experiencing currently. So they've been there where they didn't know where to go to get help for, or how to make a doctor's appointment, or how to do all of these things that they now know how to do because they've been trained, and they can offer assistance that way. And so because they're from the communities already know them. That they're really familiar faces. They're always at the community events because they're participants in the community.
Another question that came in was, sorry, 1 second. Do you occasionally survey the attendees to gauge engagement, like figure out their likes and dislikes and building accountability?
I think that the community health workers do get some feedback there. We haven't done a more formal survey, but that's a good idea.
I think in the early stages of this grant, we really just had so much to implement. We had to train the staff. We had to have them put together some modules, trying to get our partnerships in the community. And we'd love to be able to, now that we've got it more established, to do some of that evaluation on it.
And our other grant that we have, the Minority Health Initiative, we do some of that evaluation through that grant, but it's not specifically for this one.
And there was a question on what kind of grant did you receive for this project, and would you grant permission to other organizations if they would like to replicate your program at their sites?
So we received funding through the state. The Minority Health Initiative grant was the initial grant that we had, where we were supporting Vietnamese immigrants and refugees. And then the same year that we received this grant, we also expanded those services, and we got another grant from the Community Health Endowment in Lincoln. And that one was specifically to target and support and provide education around diabetes for immigrants and refugees. So having those two grants really, really helped us enhance these services. And we would love to help people establish this in their own communities. So I would definitely want to offer any support we could do with that.
Absolutely. And we're, you know, if you want some of the results of our focus groups or anything that I think we have some other materials towards the end of this grant where we'll be kind of putting together a description of what we've done in a more kind of longer narrative, I guess. So we'd be willing to share that too.
That's great. Another question that came in was, does the center offer services to undocumented?
We don't track if people are documented or undocumented at the Asian Center. Most of the clients that we see are documented because they come to us. They're qualified for services, so therefore they have to have documentation. If you're a refugee, you have documentation. You've gone through a long process of sometimes up to 2 years to even apply in your sending country to even arrive in Lincoln in the first place. So you definitely have documentation. But we do work as partners with other agencies such as El Centro de las Americas, and they provide services to mostly the Spanish-speaking population in Lincoln, Lancaster County. And we have lots of great community partners.
Great. Another question that came in was, you mentioned the focus moving forward on pregnancy. What might that incorporate?
So right now, we don't have a huge focus on pregnancy. We started the prevention model for the youth to be more of a nutritional exercise model to understand a little bit about diabetes. I think we're kind of in process with the pregnancy module for the women. It wasn't a huge focus of the grant, and we don't serve a lot of...
Not specifically. A lot of our community health workers are also trained as community breastfeeding educators. So they're already going out to women, and they're able to offer this kind of one-on-one education about gestational diabetes at that time. So they have the training and they use it in that capacity.
Okay. I think those were all the questions. Let me just double check and see if we might have missed any. I guess another question that came in was, how will you sustain this project after the grant is over?
Well, that's always the million-dollar question, right? With our community partnerships that we've established, I think that even if we continue to only have the Minority Health Initiative monies, we'll still be able to benefit from this enhanced look at diabetes and diabetes in a refugee and immigrant community. So the staff will still have that education and be able to provide those services in a more intense way.
We also have the partnerships that are already set up with the colleges, with Action Now, with people in the communities. So those screenings can still likely happen easily. Those, don't cost us something. No. We've got the newsletter in place. We can make that, we can always have a segment of a newsletter that focuses on diabetes. It might not be the whole newsletter. But there's definitely sustainable practices, I think, that have been built in. Also, the client base that is now regularly working with our community health workers will not go away, because they really rely on their services for lots of different things, like, being able to go to the pharmacist and sort of help with their medications or checking in on their their exercise or checking in on what they're actually eating. So we know that they'll continue to serve the people that we've already identified. But it'd be great to have another grant.
Yes, it would.
And I guess while we still have a couple minutes, would you mind talking about what challenges you've faced in general in this work?
Well, the challenges sometimes can just be convincing clients that they should care about diabetes. I mean, that's often the complaint that I hear the most from my community health workers, is that sometimes they feel like they're not making a good enough difference. But you know, for every one person that they can't seem to help, they identify and find several more that they can. So that's a good thing about that. Other challenges?
I think one of the major challenges that we've had, and this isn't really something that's so much client-based, but it's sort of probably just the dynamics of running a really busy place, is we really wanted to be able to, do things neatly, to always track things, to have a database, to have, to do some evaluation on some of the modules that our community health workers did. But they're so busy doing so many different things that it's really, really difficult to have them meet the needs of all of the clients that come in and really be perfect at documentation. Right. So that's a continued challenge, I think.
Yeah, that's exactly the challenge. So the Asian Center is a relatively small agency compared to lots of other sort of larger programs because of our narrow focus on immigrants and refugees. So we, previous to having this grant, tracked all of our data in an Excel spreadsheet. And there's not a really great way of combining and analyzing and doing all of that. So what this grant has highlighted to me is the need for some more robust tracking system. So I am pursuing other funding to do that.
I think one thing that I learned working with Sheila over this too, as someone who is helping to write a grant, is that we were so ambitious when we set out to do this. We really felt that we were going to be able to track A1Cs and understand the changes in those over time and all of that. And what really needed to happen first, that's a great long range goal for us, but what really needed to happen first was that we really needed to be able to provide all of the services for the clients and have a database and all of that. So I think my advice to someone who's kind of starting from the ground level up is to make sure that you set really, really manageable goals with what you're doing, and make sure that that you really realize how much time it's actually going to take, because everything probably takes about twice as long when you've got, for instance, language challenges and all that. Yeah.
Great, thank you. It looks like that was the last question that we have on here. So do you have any other, final thoughts or lesson learned you wanted to share with the group?
We feel privileged to work with the staff and the clients that we do. We think that it is a great model, and we think you should do it too.
Yeah, we're so excited that we were able to tell you about what we've been able to do over the past few years, because it's really exciting to see a healthier Lincoln.
Yeah.
Okay, thank you. Janelle, did you have any final words you wanted to share?
Yes, can you hear me?
Yes.
Yes.
I just wanted to thank all of you for attending, and certainly to thank you to Sheila and Susan for an excellent presentation, and to all of the attendees for their insightful and thoughtful questions. So on behalf of the Midwestern Public Health Training Center and the National Diabetes Training and Education Advisory Committee, thank you for attending today. I want to remind all of you that if you wanted to view this again, it will be archived, and we will be sending out a link to that. And so if you know of anyone that you think could benefit from seeing this as well, please let them know that it will be archived and available to them within the library as well. Again, thank you for attending, and happy holidays, and look forward to 2018 when we'll showcase our next MINC diabetes webinar. Until then, thank you.
Thank you.
Thank you.